So thank you, Dom, and thanks everyone for coming. I will be brief, but it's really my pleasure to introduce Walt Sipe to our first intensive services grand rounds of this year. Walt completed his undergrad at Harvard, med school at UC San Diego, back to the East Coast for Children's Hospital of Boston for pediatric residency, to UCSF for PEDS GI fellowship, and then he and I actually have the distinction of starting at LPPI on the same day, July of 2008, when I first came here as an attending, and Walt started as a second-year resident in psychiatry here. So we have since kind of grown up together in a way at UCSF, and very fond of both those times and all the work that you've done since then. He now teaches some here, is still has a % faculty time in the PEDS department and a private practice. So we thought when Dom and I were strategizing who to invite for intensive services grand rounds, given the overlap between the GI tract and the CNS, we instantly thought of Walt as someone who could be interesting and speak to the connections between these two areas of the body. So thank you very much for coming. Really a pleasure to have you.
Thanks, my pleasure to be here. I will point out that even though Andrew said when I came in I started as a second-year psychiatry resident, that was actually my PGY 8 year. So this topic, I'll kind of be looking at, just talk a little about the dynamics of restrictive avoidant eating disorders. But I think a lot of, it's sort of an exemplar, but some of these practical principles that can apply more broadly, because really the disorders of brain-gut interactions and the way in which those two systems show up, I think is really quite ubiquitous. Right? So there's my obligatory disclosure. So really, one of the principles that is very dear to my heart, I view myself as an acceptance commitment therapist. And so one of the fundamental things I'm tracking almost in any clinical situation is symptom avoidance and experiential avoidance. So in thinking about when I kind of not all disordered eating is an eating disorder, in quotes, obviously restrictive avoidant disorders are in that chapter. But when we typically think about eating disorders, oftentimes either bulimia nervosa or anorexia nervosa are kind of held up as sort of the prototypical types. And I want to just discuss how what can behaviorally look very similar in terms of patterns of restriction, nutritional deficiencies, actually has a very different behavioral underpinning. And I think holding those separate is really key to understanding what our patients are dealing with and developing alliance and treating them effectively. So in terms of objectives, I want to give you a sense of how oftentimes restrictive avoidant eating disorders can arise in the context of functional GI disorders. That's the work I do at the Children's Hospital, things like IBS, functional dyspepsia. As I just said, kind of getting into the importance of addressing distinct patterns of motivation and really looking at that and kind of a reminder of principles of behavioral conditioning, going back to Pavlov and B.F. Skinner and Watson and classical and operant conditioning, I think is really critical to being holding in your mind. And if you take away one point, it's this. I literally buy Chinese finger traps by the dozens, and very few people I work with, either clinically or in supervision, right, Ryan, get away without getting a Chinese finger trap. Because in many ways, this is a model of sort of the human mind, right? If we think about how a finger trap functions, if this represented any unwanted experience, internal, external, whether it's social, something dysphoric, a sensation, the initial impulse is to pull away, right? We all, as human beings, in fact, as creatures with nervous systems, we all have this motivation to move away from that which is distressing. And yet, in this model, the pull away functions to actually have us more tightly gripped by that which we're avoiding. And of course, if that cycle goes undistinguished, the motivation to avoid increases. It's tighter, it's even more distressing. So we up the intensity of the avoidance mechanism, and so on and so on. And so this happens all over the place. So this is a core metaphor that's broad, but when we look at patterns of restrictive avoidant eating, you can really see this playing out. Right? So let's just I want to think about something I presume most of us are going to be more familiar with. It's just dealing with panic disorder with agoraphobia. Right? So if we think about that, what are the criteria? Well, it's panic attacks, right? And then the agoraphobia that goes on top of that, right? Anxiety about being in places or situations from where escape might be difficult, right? Or help might not be. It's like that fear, I can't get out of something. And it typically involves characteristic clusters of situations. Right? And the situations are avoided often at great cost to social occupational functioning. Right? I presume most of us have already seen that if we really think about it, you ask someone with panic attacks, even severe panic attacks, what proportion of their waking life are they actually having a panic attack? It would amount to minutes. Even for the most severe cases, if you added it all up cumulatively, it wouldn't probably even be an hour a day. And yet, almost their entire life is organized around avoiding a panic attack, right? And so in that model, that's where you can see if the finger trap was the panic attack, that constant pulling, that constant avoiding, I can't go out, is the real cost. So in a sense, the avoidance is far more costly than the symptom itself. Now, I started in gastroenterology, and I probably should take the quotes off of this, right? Because I said, well, let's just call something IBS with agoraphobia. The more I've done my clinic, the more I actually have seen irritable bowel syndrome with agoraphobia. No quotes needed, right? But what if we just take, this is not from the DSM, but let's just substitute panic attacks for something like IBS flares. A sensation of sudden, uncontrollable abdominal discomfort or bowel urgency. What if we use the exact same criteria for agoraphobia, but again, the anxiety is about being in places or situations where escape might be difficult, or in which a toilet is not readily available. That's a classic fear in the event of an IBS flare. Typically involves characteristic clusters of situations, and the situations are avoided, often at great cost to social occupational functioning or nutritional status. So again, this is now broadly speaking, the greatest disability and distress in many conditions is often sourced in the maladaptive avoidant behaviors themselves, right? So we're thinking from somebody that's already has a functional GI disorder like dyspepsia, or it might not be functional, they might have severe reflux, they might have chronic nausea, but you get deconditioning from lack of activity, trigger points from splinting. That's when people are with chronic pain, splint, and they hold themselves in a position that ends up causing more problems. Malnutrition from food avoidance, and isolation and depression from schoolwork and social withdrawal. Right? And malnutrition from food avoidance can be a really, really big one when it becomes severe. Right? So I want to give a case example. And this is actually someone who first presented to a GI clinic. But I think it's a very dramatic, but I think it illustrates how an avoidant pattern can really get started. So this individual presents to an outpatient GI clinic for complaints of severe abdominal pain and diarrhea. There's no structural or inflammatory abnormalities identified despite extensive evaluations. So this individual had upper, lower endoscopies, I believe had a gastric emptying study. And the history includes severe dietary restrictions leading to profound malnutrition and severe nutritional deficiencies, including scurvy. Do you know how hard it is to get scurvy? This is not cutting edge medicine, right? James Lind in the mid 18th century did the research that citrus would cure scurvy. So you really, really, really have to be restricting dramatically. I've only seen 2 cases in my entire medical career. The other one was when I was in Boston Children's Hospital as a resident, was a child who was severely, severely developmentally delayed, was being cared for by a grandmother who didn't have adequate resources and basically was just getting fed milk, right? So this patient actually had the diagnosis of irritable bowel syndrome, and he actually sort of understood it, but he was skeptical because the severity of the pain experienced during an episode. I'm going to come back to that because the idea is, we're wired, if something really hurts bad enough, it must be telling me that there's a problem, right? If the symptom is bad enough, there has to be something underlying the symptom that is just as severe as I'm experiencing the symptom. So he lives in constant fear and anticipation of having a pain episode and having to spend excessive time in the restroom, right? So basically he's been progressively isolating, right? He doesn't have any poor or distorted body image, right? In fact, he's adamant that he wants to be able to eat more. He's angry that he can't eat more, and he says he misses many of the foods that he enjoyed in the past. Already very different than sort of when you're starting to think of somebody with a prototypical eating disorder. And yet this individual was restricting to a degree that many anorexics could only dream of being that successful at. Now he had some illness models in his past. Both parents struggled with chronic illness, and his mother had IBS. Now here's the critical thing. In response to childhood distress, his mother would eliminate possibly offending foods, leading to temporary relief. So starting at age 11, this patient progressively eliminated all items from his diet except beef and white bread. So he could eat a hamburger plain. Ketchup would have solved the scurvy issue, but that was out. Right? So in a sense, what was happening? He had childhood functional abdominal pain, had parents that had an illness model, so they eliminated the food. Temporary relief. So the elimination of the food was reinforced. The symptom came back, but they didn't reintroduce the food. They picked another food to eliminate. Temporary relief. Symptom came back. Now, again, extreme, but you kind of see how this pattern evolves. Each step making sense inside of an illness model where the pain is caused by a problem. I eliminate the problem, it gets better, therefore that was part of the problem. So let's just go through the diagnosis. I'm not going to talk too much about anorexia and bulimia other than to just kind of bring the criteria to the front of our mind. So anorexia, typified by restriction in energy intake, necessarily leading to a significantly low body weight, right? That there's an intense fear of gaining weight or becoming fat or persistent behavior that interferes with weight gain. Right, so already part of the criteria of anorexia is this intense fear of gaining weight. The restriction is a strategy, or a part of it is actually in the fear itself, right? And there's a disturbance in the way in which one's body weight or shape is experienced. So it's a real misperception. There's one of the fascinating pieces of data I saw, I think it came out of the Netherlands, but they actually did a study where they compared individuals with anorexia versus normal controls. And what they did was they had them walk through doors or thresholds of varying width. And eventually, if you get a narrow enough percentage of you're going to turn sideways, you don't hit the door. Individuals with anorexia actually turn sideways in a wider door. Well, that's fascinating. So it really is, there's almost a perceptual component even as you're moving your body through space. So bulimia, recurrent episodes of binge eating characterized by, right, so these binging in food that is definitely larger than most what people would eat, and then a sense of a lack of control. So in this sense, it's a kind of an under control about impulsive eating. Okay. And again, there's compensatory behaviors in order to prevent weight gain. Okay. And again, self-evaluation is unduly influenced by body shape and weight. Right, so in both of these, you have kind of a lack, or you over control or under control around feeding, but then ultimately it's driven by a sense of self-perception. So restrictive avoidant food intake disorder. It's kind of going to be a broad category, and I'm going to talk about a particular example of this using our case study. Right, so it's an eating or feeding disturbance, so it can be a lack of interest in food, or avoidance of food, or concern about aversive consequence of eating, right? Which leads to persistent failure to meet nutritional needs. So there can be significant weight loss or significant nutritional deficiency. Unfortunately, in our PGI clinic, we actually have individuals who have avoided to the point where they become entirely dependent. They're on NG tubes, NJ tubes, and the family actually they are waiting for the symptoms to go away before they're willing to do an oral trial. Right? Marked interference with psychosocial functioning. And look, this is actually mutually exclusive with anorexia and bulimia and neurosis. In fact, there's no evidence of a disturbance of the way which one's body weight or shape is experienced. So like in eating disorders, the course is highly variable, it's chronic, there's a high comorbidity. And so in those classic eating disorders, there's usually some feature, fixation, or obsession with body image or eating habits per se. Now, there's also just a term worth mentioning. I may have heard the term orthorexia. Right? It's kind of a useful, I think, term to hold, where oftentimes that's like orthodox food, where foods are assigned a particular value. Right? You often kind of see this with individuals who take on very strict diets, right? And kind of like almost like a cultish following to sort of certain foods, or sort of taboo, where certain foods can often be a cover, sort of a more socially accepted version of restriction. I'm not going to say too much about it, but it has its own kind of presentation. But I want to go back into sort of this how in these avoidant restrictive patterns, right, that really understanding the suffering as a resistance or experiential avoidance playing itself out in a sort of a self-reinforcing loop. So I want to just review some classical conditioning, right? So this caption says, this is a dog in Pavlov's lab. Watch what I can make Pavlov do. As soon as I drool, he'll smile and write in his little book. What's funny about that is that's actually entirely accurate. Right? Conditioning does go both ways. Okay? And by the way, Pavlov actually won the Nobel Prize in medicine, I believe it was 1904. But where this is really, really relevant, and if you work with any kind of population that has this sort of restrictive pattern based on what they're saying is a fear of abdominal distress, right? Is Bearnaise syndrome. Has anyone heard of this? All right. So what is Bearnaise, right? Bearnaise is this really rich, it's basically hollandaise sauce with like chives and savory and all a bunch of savory herbs, right? So you have this very sensorially rich, it's fatty, it's got a mouthfeel, it's very aromatic, right? So there's a lot of sensory inputs coming, generally considered, high French cuisine. So imagine this, imagine you're on a cruise, and you're having your nightly dinner, right? And it's filet mignon with sauce Bearnaise. Delicious meal. Great steak, this rich aromatic sauce. Unfortunately, norovirus is now sweeping through the cruise ship, unbeknownst to you, and as you're having this wonderful meal, norovirus is now in its incubation period in your GI tract. 6 hours later, not to be too graphic, you don't know which end is up, because both are starting to expel things as fast as possible. Feel like you're going to die. Now, you may know and have an intellectual knowledge that you were on a cruise ship, viruses spread, there was no food poisoning here, the meal was cooked impeccably, the kitchen is faultless. And yet, probably for the rest of your life, certainly years, unless you do exposure therapy, you will not be able to touch a sauce Bearnaise again. The mere smell of it will have you be nauseous. In fact, seeing a picture of it might be sufficient to generate a nausea response. This is a really important point about GI physiology, that if you work with people that have abdominal difficulties is important. Because in a classical conditioning model, right, nausea and vomiting is one of the most powerful unconditioned stimuli there are. In other words, anything that pairs, any sensory contextual input that pairs with severe nausea tends to then generate a nausea response. If you've spoken with anyone who's had the misfortune of going through a highly emetogenic or a nausea-inducing chemotherapy regimen, they will tell you this, right? Individuals who may be well into remission for years will often describe they won't be able to get within 100 yards of the infusion center without having a violent nausea reaction. Simply that conditioned response of the chemotherapy with that place is enough to reintroduce that. Actually, one of my GI colleagues even described one further step removed, that her mother went through chemotherapy, and after their infusions, they went to Panera. And she couldn't even go into a Panera with the family for years, and she finally essentially did exposure therapy, and I'm going to get over this. But it doesn't resolve easily. This is very important because for individuals, oftentimes that's the first line of an avoidance. We naturally avoid that which makes us nauseous. And it has a very strong evolutionary background if you think about it. Right? If you eat bad food or a poisonous berry, you're lucky if you get a second chance. So evolution has selected us to be highly avoidant of anything that's associated with nausea, right? And if you think about it, if you eat like 4 different berries and you're not sure which one you're going to associate with all of them. And this is very highly conserved. You know, in studies with mice, if you irradiate a mouse after you give them just plain water or like a very sweet syrup that they would be highly selected for, if you irradiate a mouse sufficiently to give them nausea after eating that sugar, they won't touch it again for the rest of their lives. So understanding how powerful this is important, because subjective experience for a patient is always going to trump your explanation. So if their body is saying, this is bad, this is dangerous, this is to be avoided, simply saying, well, no, it's okay, is not going to cut it. You have to be able to create a model where they can understand how they're having the response they're having. Now, after classical conditioning, that was Pavlov's work in the early 20th century. Kind of mid-century came operant conditioning, right? He's kind of most classically associated with Skinner. And so this is where we had the terms, punishment and reinforcement. So essentially, from a behavioral standpoint, if you take aside all kind of our childhood associations with punishment, punishment is simply anything that decreases a behavior. So if you have a behavior followed by some context or consequence that subsequently reduces the behavior, that's the definition of punishment, right? So if you're adding something that decreases the behavior, that's positive punishment. Like classically, if a parent's thinking that way, it's spanking, right? Take away the toy, negative punishment. Both are strategies to decrease the behavior. Reinforcement is simply any consequence that increases a behavior when it's followed by. So in restrictive avoidant eating, oftentimes in this model that's triggered by somebody who often has abdominal pain, whether it's functional or not, or somebody who's highly anxious where they happen to have overgeneralization, they were nauseous, they eliminated foods, and they continue to overgeneralize, you really see very behaviorally how actually natural conditioning mechanisms can push somebody into what would look like a highly pathologic condition. Right? Because this is supposed to say eat. Okay? So if you have somebody like now who, take our individual in a case where he was already having a pain model, and there was an expectation of pain when he ate, which was subsequently concerned, in a sense, eating food was punished. Right? If you have pain or nausea around a food or approaching a food or even thinking about a food, that serves as a punishment. At the same time, avoidance is basically negative reinforcement. If I take away that food, if I restrict, either in terms of the amount I eat or the range of what I eat, that's essentially that behavior is reinforced by the short-term removal of this noxious visceral stimuli. That makes sense? And the problem with these very visceral mechanisms is reinforcement always works better in the short term. Right? The more proximal a reinforcer or a punishment is to the behavior, the more effective it is. That's why, if you're good parenting is if like a child has some behavior you want to intervene on. You don't say, I'm busy now, but you're going to get it in, a week from now when my deadline passes and I can deal with you. It's not going to be very effective, right? And so the problem in the avoidant restrictive eating in this is that you have a lot of short-term reinforcement for the actual avoidant behaviors because it's right there. You have very visceral noxious stimuli, and yet the costs are discounted. You don't really feel a nutritional deficiency quite the same way. Okay? As you become disconnected from the social consequences, those diminish in terms of salience relative to what's there right in front of you. Okay? So from that standpoint, you can see how there's this vicious circle that can become established very easily. So you have food items or eating becomes associated with some kind of noxious reaction. So oftentimes the cycle was triggered, somebody had an infection, or they may have actually had a legitimate allergic reaction to a small item, or there may have been like particular social cues, right? Somebody they vomited, like they got sick and they vomited on a date, or there was severe embarrassment, right? So then that reaction subsequently is because it only takes a single learning example to kind of create the conditioning. So the next time that avoidance behaviors leads to short-term relief, right? And then you it reinforces the avoidance. And then in some individuals, those associations generalize to larger and larger and larger category stimuli. And this is why oftentimes you see individuals with coexisting anxiety disorders are more prone to this because, in fact, one of the features of individuals that are very prone to anxiety is that they will tend to overgeneralize fear and threat. So that can be both, we often think of it cognitively, but it can also be an overgeneralization of visceral threat. So again, it's this constant pulling against and resisting these incredibly noxious stimuli, and then not distinguishing that the avoidance is now perpetuating the cycle. So that's the little finger traps, and then of course, I'm not going to go too much into mindfulness, but that's kind of a reminder of one of the images. So oftentimes when dealing, both if you're dealing with them in kind of a mental health setting or in a GI setting, this primary focus on symptom control and diagnostic maneuvers can inadvertently reinforce and validate a patient's dysfunctional behaviors. Right? Now that's a little bit more pointed towards the gastroenterology side, where if you keep looking for, well, let's do another endoscopy, let's do another scope, let's look for allergy, you're kind of validating that mindset of there's really a problem here. On the other hand, right, the symptom may be the source of attention, but it's really avoidance is the real problem. So again, if you're working with these clients, now to kind of, hopefully it's starting to show up, but if you are interacting with somebody like they're restricting in order to lose weight, or in order to control their environment, or you give them kind of kind of take another step and give like a psychodynamic interpretation that falls flat, you're already lost. Because you have somebody here who's like, I want to eat, and I can't eat. Why does people, and I see this a lot in the gym, why do people keep asking if I want to lose weight? I don't want to lose weight. Right? So understanding that avoidance is the real problem, and it's actually quite natural. Right? It's very understandable. It's not workable, but it's understandable. And I think that's one of those things, is really getting that it's a very powerfully conditioned responses that you're dealing with there, right? So part of that approach then is, the first is the psychoeducation. I mentioned this earlier. You have to have an explanatory model that fits a patient's subjective experience, right? That's why I spent so much time talking about sauce Bearnaise syndrome, for example. Because, and I actually will talk about that in a moment, that's where I actually use evolutionary models, right, to actually give those to patients, because when you put something in the context of this is a powerful survival mechanism, then it starts to make sense. And I'll talk about that in a second. But the point is that already you have to be able to work with somebody so that they get a sense that you understand their experience, but you're giving them an alternate that allows them to have their experience. Rather than them arguing, people keep saying I should just eat, they don't understand how bad this is. Or, our first patient, if I'm hurting this bad or I'm this nauseous, then I must be allergic to all these food items. The second thing, and this is a very big concept from acceptance commitment therapy, is generating willingness. Okay? And again, this framing avoidance not as pathological, but as unworkable, kind of follows from the psychoeducation, right? What do I mean that it's not pathological? Obviously, it's causing problems, right? And at some level, if we're using the DSM, you're making a diagnosis because it's interfering with social occupational functioning and it's causing nutritional deficiencies. But what I mean that it's not pathological, in a sense, it is actually, it's sort of the opposite. It's the over-application of survival circuits, right? It's actually, it's survival-based, right? If you think about it, it was highly selected for to be highly suspicious, highly avoidant of any sort of food item that may be causing distress. It's unworkable though, because ultimately the strategy of avoidance is taking them away from what really matters. And then the last piece, and I'm not going to say a lot about this because actually, it's really the approach is exposure and desensitization. And if you can get this and this, then this kind of fits, I think, really into models that are pretty well established for phobias and, for example, OCD. But I'm saying this because hopefully what's leading is there's one pathway you go down for well-established treatments for anorexia and bulimia. But if you try to slot somebody that's got restrictive avoidant eating into that sort of eating disorder model, you're never going to get past here. Because they're going to be like, why do people think I don't want to eat? Right? When in fact, the mechanisms are much more similar to a phobia, right? Well, I get near that thing, I get really scared, it doesn't feel good, so I move away from that thing. Of course, there's a cost to moving away, right? Or even kind of OCD is a better model. I have this concern, I have a thought, this is internally very distressing. What do I do to minimize my immediate distress? What behavior can I engage in? And why does OCD perpetuate? Same thing, it's behaviorally reinforced. Most compulsions do create a temporary alleviation of the obsession, which unfortunately reinforces the behavior, and then you have to look out, and then the consequences, there's an unworkability to it. So I'm not going to say too much more about that because there's already a lot of experience with those. So, but again, the psychoeducation piece, to put that a little bit more detail, and I want to make sure we have some time for discussion, right? But again, this is a little baby bear like looking for berries. Right? So the psychoeducation piece that I really try to put in place is helping somebody understand that this is indeed a cycle's been triggered where now food is conditioned and becomes aversive. And there's a natural, very powerful move away from what's aversive. Right? And I will create this with them. I'll create the sauce Bearnaise syndrome with them. And I will actually use other animals. What would happen to creatures evolutionarily, if you got sick when you tried a couple, well, was it that, or was it, you don't get a second chance. That's very helpful because if you can work with somebody, by the way, one of the advantages of using evolutionary metaphors, right, and you actually start to use animals is it kind of really creates, this mechanism is not personal to you. You really want to depersonalize something, dehumanize it in a sense. We're talking about pattern brain circuits that actually were there longer than we were as human beings. So it creates a way of actually understanding the experience that puts it in a position you're not doing this to yourself. Okay? Now, the next steps, we're going to have to learn a more workable way of doing it. Right? So the willingness piece starts with acknowledging the competing motivations to avoid distress and engage with food. Right? That's the dilemma that oftentimes is arising for people that are having, particularly if they have a coexisting GI disorder. Right? But again, this can, once nausea or food aversion has been conditioned, it can kind of become its own flame. So that, you have to acknowledge that, of course you want to avoid the distress. I mean, that's all, it feels terrible. And I get it. I believe you. You want to eat. You're not trying to lose weight. I mean, nobody tries to get scurvy, right? But, and again, I kind of talked at this, it's not pathological in the sense that the instinctual survival mechanisms are in play. But it's unworkable in the sense that avoidance is ultimately incompatible with long-term values. Right? And that's, again, I'm kind of coming from an ACT perspective. But part of what we do in ACT when we do values work, in terms of what are ways of being that are inherently important to you and motivating, is that when one becomes disconnected from their values, actually the cost of the avoidance behaviors becomes minimized. And you can really see that in somebody who is has been agoraphobic for a long period of time, right? Agoraphobia can be horrendously difficult to treat, not the least of which because they've got to get out of the house to get to your office, right? But if you work with individuals with severe agoraphobia, they've been inside for so long that they become disconnected from what they're actually missing out on if they were to get out of the house. And that makes treatment much more difficult because, again, well, if I leave the house, I'm going to have a panic attack. That's right there, that's visceral, that's aversive, I don't want that. And if they've gone on long enough, well, I don't know, my friends weren't that important anyway. I watch Netflix. The cost becomes minimized. So this is another piece in generating the willingness. It's not just lowering what we would call as the maladaptive behaviors, because they are maladaptive, but they are serving a very important function to avoid distress. And as you know from doing exposure work, which we're leading into, distress goes up in exposure work before it goes down. So there needs to be something, in a sense, to make it worth it to actually stop avoiding. But you can't promise them that, like, again, nausea, it's such a powerful conditioning response. You can't wait for that symptom to go away. You actually have to, like any exposure, contact it before it goes down. So defining values in terms of what matters to you. What would be possible if you weren't avoiding? What's the cost? And spending some time highlighting what would be the payoff. Why would it be worth it to endure, at least for a time, noxious visceral stimuli? Right? That's what the values piece is, right? And then, so again, the exposure stance is the therapeutic stance would be much more aligned with phobias and OCD than it would be somebody with anorexia or bulimia. Now, I should say, I've kind of simplified this because obviously individuals that have anorexia can use abdominal pain, right, as a cover, right? That hurts me. And so I'm presuming that that's some of the subtlety, but I just want to acknowledge that, right? But, again, a hierarchy of fears. What would be the hierarchy of foods? Which one would be the first one you'd be willing to, for example, reintroduce? Would you be willing to be in the presence of it? What are your fears around? What's worse, nausea or vomiting, right? So actually looking at, like, trying to get the way you would do with any exposure. Working with slow incremental progress with well-defined goals, right? Doesn't work to send, unfortunately, my GI colleagues are probably guilty of this. Like, oh, you don't have any allergy, just go ahead and eat normal, right? And you will have some people that will do that. And they're like, okay, I'm going to do it. I'm just going to go to a steakhouse now. And of course, now it's just the system is so overwhelmed that there's going to be a conditioned response, which may include violent nausea, intense pain, unless they really, really understand and are deeply kind of grokking, okay, what are we doing with exposure? That would just be a setback, right? You don't take somebody that has like severe fear of flying and then just like send them to Hawaii, right? Without even like, hey, we should just drive to the airport first. Hope that didn't come out very well. So also, and again, an SSRI adjunct therapy can also be important. So what this says, sorry about this, this is always with a microtitration at onset. That's like another pearl, I would say, for those of you who do med management in the audience. Individuals who generally are hypersensitive to their condition to abdominal stimuli, their condition to nausea, they have functional GI disorders, are generally very interoceptively sensitive, which means they're acutely aware of what's happening in their gut. These individuals, and they're often anxious too. My experience is if you start these individuals with an SSRI, even at a low dose, I'll start 25 milligrams, you can split a tablet, it will be intolerable. It will be intolerable. So if somebody comes into me with, my personal preference would be, I usually start sertraline at 2 milligrams. That's my starting dose of sertraline, right? And I do it with a liquid, and we tolerate and go up by 2 milligrams every day or every other day. So that they're actually tolerating, we're kind of starting homeopathically, and we skip those initiation side effects, right? Because SSRIs just have too many kind of, on start, too many visceral sensations. They often worsen anxiety. And in fact, that's actually my go-to now for almost anyone who comes in with a lot of somatic anxiety, whether it's GI or not. I've just had a lot of success with it, and I think it's a lot more tolerable. So, but particularly anyone that has gastrointestinal issues, really think about starting SSRIs with a liquid. It maybe delays you getting to a treatment dose by a couple of weeks tops, but it's generally worth it. And the way I would use an SSRI in these individuals, particularly if there's a lot of hyperarousal, a lot of ruminations associated. The other medication, which I should have put up here, which you can probably guess, would be mirtazapine. And mirtazapine is actually can be very effective. In fact, in our pediatric GI clinic, most of the pediatric gastroenterologists are getting pretty used to using and initiating mirtazapine, even in the absence of anxiety or depression, simply based on its GI side effects. Because it is a very powerful appetite stimulant, it's a powerful antiemetic, and it can actually help reduce abdominal pain. So from the standpoint of mirtazapine, is often can be very helpful in the sense that even as you're breaking, you're doing exposure, if you have a good response to mirtazapine, you can often reduce, like essentially if you have an intense appetite stimulant response, it's somewhat inconsistent, although not entirely, with a kind of intense aversive nausea response, right? I mean, if you're really hungry and you eat, all of a sudden eating becomes reinforced. So that's where mirtazapine can also be a really helpful adjunct in these clients, right? Also, probably a little bit of a test if they're really freaking out about the weight gain of mirtazapine. Maybe you have to rethink: is there something about the body image that wasn't caught? Okay, and then again, repeat the first steps as necessary. Going back, doing the psychoeducation, making sure they understand how this vicious circle works, so that what they're doing actually makes sense, rather than it's just you occurring as somebody who's just not getting how sick they are, them going to the gastroenterologist, is this really a problem, and then kind of ping-ponging back and forth. So then keep doing the psychoeducation and the willingness work. Okay, so we got a little bit of time. I hope that gave you a little bit of a useful perspective, and I'm open to any questions the audience has right now. Yes?
More of a comment. I think if we're thinking about this as from like a survival mechanism, instinctual origin.
Yeah.
But then as it progresses, one would think that if somebody were so malnourished they were getting scurvy, that there might be a flip in that, right? In the sense of, if you're getting yourself walked into a situation where you're equally at peril of dying.
Yeah.
How might you comment on that?
Yeah, you kind of would think that from a rational basis, but remember, their body is giving them lots and lots of evidence that what they're doing makes sense, right? So, I mean, again, getting scurvy, that was an extreme case. But in his, every time there was a food elimination, right, there was actually a temporary improvement. And every time he did a food challenge, there was intense pain. So more typically, if that cycle is showing up for somebody, what you're dealing with is they're gonna blame the nutritional deficit or the lack of weight, even though I know the weight's a problem, but it's a problem because I can't tolerate food, rather than it's a problem because my avoidance of food. Right? So the flip still goes on to food causes me pain, therefore causally I don't eat, therefore the problem is the food that's causing me pain. rather than the rehab approach, which is, yes, food causes you pain by conditioned responses, so we need to start walking that back, and can you be willing to tolerate more pain in order to be more healthy? And in fact, the other vicious circle I didn't talk about is that when people oftentimes get into a situation where they restricted sufficiently that they either have a calorie or nutrient deficiency, oftentimes the pain gets worse, right? Because now you actually have a biologic, perturbation going on. So oftentimes that is, so if you can get kind of past that first hump, and that would be your goal, is if you can oftentimes get a little more weight on and they can tolerate those first sessions, they feel better when they gain. That could be a motivation, a positive reinforcement to eat that starts to develop. So that's also part of where you're going. Other questions or comments? Yes.
I'm just wondering, for these patients, where are you usually referring them? Because one thing that's coming up for me is that I'm thinking about a case that actually we shared together, a young adult who, exactly what you're talking about.
Right.
And now I'm thinking about it, and I'm like, it just was so slow doing exposures week after week and having her do exposures outside of session. And it feels like we should be creating like an IOP for these patients to be coming to and practicing this stuff every single day for several weeks. Or I'm just wondering, what are your thoughts on that? And
I think a lot of it is, this is why I'm excited to give this talk, because people just find their way to my GI clinic, and I'm sort of this unicorn that's there for one day a month. So I think a lot of it though is, I hope is for individuals that already have experience, for example, with OCD or with phobias, is that already there's the mindset right there. There's already the skill and experience to, I think, deal with these clients. A lot of it is just the confidence as clinicians to hopefully have a GI team that can kind of work somewhat to reinforce that this isn't dangerous, and to just understand enough of the conditioned response that you can then just slot this in the same way you would deal with a phobia. Although the triggers, there may be more of the physical reaction instead of the sweating, the flushing, the hyper adrenergic feelings of someone having panic may include more visceral symptoms. But that really, if you kind of get this model, if you're already doing that work, yeah, it could be slow going, but it can be slow going with people with OCD, and it can be slow going with people with phobias too. But that if you have that skill, actually translates very well. And so what I would say is that for those people that are already doing work with phobias and OCD, that this would be something actually you are better at treating than you realize.
What's interesting, because I'm in the eating disorders program, and we don't get very many IBS related ARTHR cases. We get more of the fear of throwing up cases when it comes to a fear of a visceral response.
Right.
But I'm just wondering where those cases might be going. They're probably still getting tested in multiple GI clinics. Yeah,
they do, and you get the same thing, and you're going to get, it's not IBS, but it's the similar thing where it's, like the emetophobia, but oftentimes, like I said, because nausea, IBS, there are people that are very well adjusted that have IBS, and they're like, okay, if I have coffee or I don't get enough sleep, I'm going to have an IBS flare, and that's often what a treatment for a cure looks like, is can you be with the symptoms. The emetophobia, often that can be just the slightest, it's like a forest fire. You just have something like a sauce Bearnaise, or you had one embarrassing event, like you threw up on a date. And boy, then that fear of I'm going to go out again socially, just the anticipatory anxiety itself can trigger nausea. Right, so that is where it can actually cycle on itself very, very quickly again. But important to understand how powerful nausea itself can condition other stimuli. All right, thanks very much.